Welcome to the monthly Virtual Infertility Workshop. I'm so glad you're here. If you're new, hey, I'm Kristin or Kiki, and I'm an infertility coach. I help women reduce the stress, anxiety, and fear associated with IVF so they can go through the process hopeful, supported, and with no regrets. Each month, I invite an infertility expert to dive deep into one area related to infertility. They share about the medical side, and I share about the emotional side. Sign up at this link to be notified about future infertility workshops so that you can join us live, and you can also get the replay sent directly to your inbox. Welcome to the November Infertility Virtual Workshop. We started this in April of 2020, so this is the 8th one. Every month, I invite a infertility expert, medical expert, to join us to talk about one thing. And this month we have Dr. Likes, who's from Fertility Center of the Carolinas. So he's the original expert, has been here a couple times. So I'm just glad that he's back here in November as we kind of get close to closing out the year, this wild year. And this is a safe space for you. This is where you can get information and also connect with people. So first we're gonna have Dr. Likes talk, and then I will share some information to help you learn. And then at the end, we turn off the recording and we stick around for the support group part, where that's where you guys can all talk and share about your journeys. This is a place of support and information. All kindness is expected from everybody. And if you are watching the replay, you can get notified about the future workshops that we do by signing up at the link in the bio. And I just really hope you come and sign up and join. It's free, and we're doing this every month. We're not stopping anytime soon. So I am Kristin Dillensnyder. In case we haven't met, I'm an infertility coach. I went through 3 rounds of IVF to become a mother myself, and I had 3 different outcomes. I had one that worked, one that didn't work, and one that ended in miscarriage. And I really found purpose through my pain and experience, and I now work with women going through infertility. And that's actually what I'm going to be talking about later today after Dr. Likes, is what coaching is really like. I get a lot of questions about it, which makes sense to me, and I'm happy to go over sort of the value of coaching and the difference between coaching and therapy. But before I talk, I want to pass the baton over to Dr. Likes from Fertility Center of the Carolinas. He is the OG of guest experts here for the virtual workshops. And he is going to be talking about sort of the behind the curtains, what it's like working at his facility, how they come up with protocol recommendations for patients. So I'm going to pass the baton to Dr. Likes.
Yeah. Thanks, Kristin. I appreciate it. I appreciate everybody being here. I see some familiar faces, and then I see some that aren't so familiar. So because of that, let me introduce myself. Again, I am Creighton Likes. I am born and raised South Carolinian. I did my med school down in Charleston at MUSC, and then I did my OB residency here in Greenville. And then I did fellowship at Duke, and I've been back here in Greenville for over 10 years now. I am the medical director at the Fertility Center of the Carolinas. So that's me. All right. So as Kristin also said, this is kind of a behind the scenes look. And what we mean by that is this is going to be a little or a lot less scientific than what we've done. So if you've tuned in to some of our previous ones, I've talked about the IVF process, the frozen process. We've had PGT. We've had an embryologist that was phenomenal. We've had just a slew of folks talk about the science and other things. This is going to be a behind the scenes look in terms of what we do from the office side, from the staff side, to arrange the protocols and kind of get you through the IVF process. So my goal is to kind of walk you through it from start to finish, and then even after finish, if we have to talk about doing it again. Caveat to all of this, each clinic has their own way of doing this. I will tell you, I've been at a number of clinics throughout my training, and it's all very similar. We have some folks that have come back to us and that now are my partners from various places. And again, it's very similar. So you'll see it's kind of a huddle and a group and team effort. And that's kind of the paradigm here. But the other thing I always mention is that it's very individualized care. So even though it's a group effort on our part, the group effort is to actually make it more individualized for each patient to hope to optimize their outcomes and therefore the success that we have. So what does that mean by a group effort? Anybody that's maybe been through this or talked to a fertility practice already knows that there are a number of folks involved. And so by that, I mean, not only are there obviously physicians involved, there are IVF nurses, REI nurses, there are embryologists, andrologists. There are a slew of people that put their input into the protocols and what we might tweak, so to speak, to optimize as much as we can. So again, this is going to be a little bit different than the scientific basis, and you're going to kind of get an idea of our thought process or processes as we talk to patients and go through the IVF protocols. So first things first, if I go from start to finish, we talk about the workup for IVF. And the workup is generally started by your physician, the primary fertility physician that you see. And that usually involves labs and ultrasounds, as we've discussed in previous conferences. And then what happens is we put a plan together, but that plan is not set in stone until we bring it to our what's called IVF conference. And every week, every Wednesday at noon, that's for us, we have an IVF conference. And so unfortunately now it's all virtual. We just had one today. But we would typically sit in a room and go through the electronic medical record of every patient starting an IVF process. And so it's on the onus of the primary physician to say, okay, this is my patient, give her background, his and her background, and say what the workup has shown this far. And then we go through what's going on with the protocols. And if you, again, have seen other conferences, there are multiple different protocols that we can use. And we put forth that protocol that we think is right, again, based on that workup. Well, then what happens is kind of a meeting of the minds. So we're around this table, all of us, the physicians, the nurses, the embryologists, our financial folks, everybody's there. And so we say, okay, what can we do differently than what this physician has said, perhaps, or what can we add that may optimize the outcome of this process? And so we have an abundant array of opinions. Sometimes that's good, sometimes that's bad. As we all know, people can disagree and agree, but it's good to talk it out. And so just know that it is kind of, like I said, a meeting of the minds. There are a lot of opinions going into just the start of the process that hasn't even been implemented yet. And so we go over the plan and we then confirm the plan based on everybody's opinion of the protocol, of the dosage of medicine that we think you're going to need for proper stimulation. Then we go through and say, okay, are we doing PGT? Are we doing freeze-all? Those sorts of things. And if you're not concerned with those phrases, certainly write into the chat and I can answer that as we go. So some of this may be scientific, but that's the plan that we put forth. And that's the first step of the process. And so then once we've kind of gone over that hurdle and the patients are ready to move forward with the IVF process, what happens is our IVF nurse, and you have individualized nursing for the most part. We actually have two IVF nurses, but it's usually an individual nurse that will contact the patient after we set the plan and say, okay, here's your calendar, here's your booklet, here's your information. The other thing I tell patients before we start this whole process is that this is a very regimented and monitored process, meaning it's not like we're just going to order a lot of medicines and say, okay, here you go, here are your injections, you start them here and we'll see you this time. It's not like that, or at least it should not be like that. What I mean is we have, like I said, calendars and booklets. We used to actually have classes for all of our IVF starts, and we would have a number of couples come in together and we'd sit around a big conference room and our IVF nurse would literally go through the calendars. Well, as you can imagine, COVID has changed all that. So now we're more virtual, but we do also more one-on-one. As you can, we can't get in groups anymore. So we do more one-on-one, but we also will direct them to the educational videos that are online from some of the pharmaceutical companies that have very good information that we would use in our one-on-ones or in the group conferences that we used to have to educate you for the IVF process. So it's a very regimented and monitored process in that regard. Once you start the IVF process, so now we're shifting into the middle part of it, from start to finish. Now we're in the process. So you may already know, some of you, that during the IVF process, what's going on is obviously you're taking the medicines that we've chosen and the protocols that we've chosen. and you're coming into the office for what are called monitoring visits. And at those visits, we're doing ultrasounds, we're doing blood work. And those visits typically are about 15, 20 minutes. And it's first thing in the morning. We start sometimes even 7:15 in the morning for patients if they need to get to work. We do their ultrasound, we get their blood work, and then they go. And what we do is the nurse, the IVF nurse, will then get the information together, and the IVF doctor of the week will sit down with the nurse every time we have a monitoring visit and say, okay, here's what we found on the ultrasound. Here's what her ovaries are looking like. Here's what her follicles are looking like. And here's what her blood work shows from what's called an estradiol level. So that's why it's called monitoring, because we need to monitor to make sure that the protocol and the dosage is where we need to be. Do we need to adjust any dosages? And so it's a very coordinated effort between the teams to sit down and say, okay, here's the information from this monitoring scan. Do we need to adjust? And once we have those orders in place, then our IVF nurse will contact the patient either by phone, or oftentimes now patients are wanting, we have something called MyChart. It's like an email or a patient portal where we can send out an email to the patient and say, okay, here's what your ultrasound and lab work showed. This is what Dr. Likes or Dr. Whoever wants you to do for today. And then we'll have you come back for your next monitoring ultrasound, because we will also time that based on the information we have. One pause real quick, and I get this a lot. I've already said it's a group effort, right? And so all the doctors, there are 5 doctors in my practice, all the physicians know pretty much what's going on at the beginning because we have that IVF conference in the start. The issue is this: we can't be on call every single day. Well, I guess we could be, but we're not on call every single day to make those decisions. And so we at our office do an IVF doc of the week. And so if there is any question, if that's not your personal patient, I will tell you at those monitoring visits, if there's any question, the doc of the week will actually come to the the primary doctor of that patient and say, do you agree with this? Is this okay for this patient? So what I want you to know, because I take that pause, is even though Dr. Fox or Dr. Von Hoff, some of my partners, may be looking and giving you the orders, it's not that I don't know about it. I can promise you, I pretty much, not stalk, but I look at every single chart that I have as we go. So I know what's going on. And in that regard, it's not like you're just at the whim or mercy of another physician that may not know you as well. It is a definite group effort and group decision. So just keep that in mind as we go. And again, that's why we start with the conference at the beginning, so everybody's on the same page and everybody knows what's going on with this patient or this couple. So once we have the monitoring and the dosage and everything and the return visits done, at some point, your follicles or your ovaries are going to be ready for the egg retrieval. And so that, again, is decided based on the conversations that the IVF nurse and the doctor of the week, the IVF doc of the week, have based on those monitoring visits. And so we'll say to you, okay, your follicles look wonderful, your estradiol level is this, you're ready for your egg retrieval. And so again, we make that decision as a group and then put the orders in and say, okay, we're going to have you take your trigger shot. Again, if I'm talking things that you don't understand, trigger shots are ones that get you ready for egg retrieval. You'll take your shot at this time. I mean, we will give you a time, usually at night, 9 p.m., 10 p.m. You're going to take your shot here on Sunday night at 9 p.m. Tuesday morning at 9 a.m., you're going to have your egg retrieval. So all that is decided at that time, at that monitoring visit, and the IVF nurse will relay that to you once those orders are done. And so then you've gotten through to the egg retrieval, and you know exactly the time frame. Now, again, another side note, all this can be done for frozen embryo transfers too, which I'll get to in a second, because that's a whole nother ball of wax. But once you have your egg retrieval, what we do is obviously we will tell you that day how many eggs are retrieved. And again, I've had this before. Some clinics will do it. Every doc will retrieve or transfer their own patients. It's almost nearly impossible for us to do that. So you may have another physician do your egg retrieval. You may have another physician do your embryo transfer. But know, again, that this is a group effort, and pretty much everyone knows what's going on in terms of what's been said. And if they don't, they ask. And so we go in with all the information we can. Once the egg retrieval is done, at our clinic and a lot of clinics, we do what's called a freeze-all. So typically you don't get an embryo transfer 5 or 6 days later. We freeze all the embryos, whether or not we're doing genetic screening on the embryos or not, per the patient's choice. And so you will get that report the day of retrieval. The doctor that did the retrieval will tell you how many eggs we got. The very next day, they'll tell you how many embryos there are. So what is the fertilization report? So again, it's a lot of conversations back and forth between the patient, the IVF nurse, and the IVF doc of the week. And obviously we are a group. So I know if I'm not retrieving my personal patient, I know what the retrieval number is, and then I know what the fertilization rate is. And so I will be able to call if need be as well. So the other thing I'll mention, and again, I'm going to back up a little bit, that's IVF getting to the egg retrieval. Okay. So again, it's a group effort and it's a concerted effort. Well, then if I just told you we're doing a lot of freeze-alls, meaning we're freezing a lot of embryos and then coming back later for what's called a frozen embryo transfer, that's a coordinated effort as well. And so the frozen embryo transfers honestly work exactly like the process I just talked about with IVF. Before your frozen transfer, we start over. So you have at that Wednesday meeting a frozen embryo transfer protocol talk. And so everybody's on board, because that's really important, because there are a multitude of ways to prepare a patient for an embryo transfer as well. So not only are there a multitude of ways to do the egg retrievals or get to the egg retrievals, there's a number of ways to do the frozen transfers in terms of protocols. And so again, this is where the individualized medicine comes in, and we put forth a protocol we think would optimize the uterine lining to receive the transfer, obviously, and hopefully have a positive pregnancy. And so you start over, basically, or we start over. We grind out the details in terms of, at the beginning, we say, okay, here's the frozen embryo. This is how many embryos they have, whether or not they did the genetic screening, how many chromosomally normal embryos they have, how many they want to transfer. That's also a very, very important point, which I'll get to in a second. And then again, what the protocol is. So our process starts over, because it's a lot of checks and balances. So we're trying to get this as quote, right as we can. And so then as you go through again, you have to go through kind of a monitoring phase, much less aggressive in terms of visits and monitoring visits, but you have to go through that monitoring with a frozen cycle, because we have to get your uterine lining prepared. And again, we're making these decisions based on the information we have from your visit, from the ultrasound, from the blood work. And again, it's the same kind of routine with the IVF nurse and the IVF doc of the week. Prior to your frozen transfer, another thing that I alluded to that's very important is I want to confirm how many you want transferred. I will typically say we're only doing one, and we're doing that to try to reduce the rate of multiples. We're also doing that because 2 versus 1, if they're good quality embryos, is not going to greatly increase your chance of success. We're just to a point where technology is there where we can feel safe and secure doing one and having a high chance of success. So we will confirm that before your transfer. Certainly, if we have done genetic screening on the embryos for various reasons, we will confirm if you know gender, quite honestly, because if we do genetic screening, we'll know the gender of the embryos. And so that's another important point behind the scenes that, again, we all talk about, like, does she know the gender? Does she know how many she has? Does she know how many we want to transfer? And we kind of get that confirmed before we do the transfer. So just like I said with the retrieval, you'll know the time. It's the same thing with the embryo transfer. Basically, what we'll do is we'll get your monitoring visit, make sure your lining of your uterus is where we want it to be, and the architecture is where we want it to be. And then we'll give you a date and eventually a time of the embryo transfer. So it's all very regimented, like I said. And again, that's based on what the doctor has seen of the development of your uterine lining and your blood level of estradiol. And then we put the orders in. Again, we will converse with the primary. A lot of times, I just did that today for a number of patients of mine with Dr. Fox. And we say, okay, she looks good. Here's when her transfer is going to be. So that kind of gets us through and kind of talks about behind the scenes. You have to realize, although you may not see it, there's a lot of discussion going on about you and you alone. So I can guarantee that. And that's for every patient and every couple we have going through. And then after the transfer, again, whether or not it's a frozen or a fresh, there's as we've discussed with Kristin before, the dreaded 2-week wait, or the TWW. There's a lot of alphabet soup in what we do. You may have seen the TWW, the 2-week wait. And that's because we typically wait 12 days before we do the pregnancy test. But that's kind of obviously the last phase, the third phase of start to finish. Was it successful? Was it not successful? So again, just as we did today in our Wednesday IVF meeting, we talk about the successes and then we talk about the failures, because the successes, yes, that's a good check off. We feel great. We're happy for everybody. But then we have to talk about the failures. And so you're at that meeting again. So you see the routine here and the repetition, because we want to say, okay, it didn't work. Why? Do we know why? The biggest thing is, again, you'll have a lot of minds and a lot of eyes looking at this from the embryology standpoint, the lab standpoint, the uterine prep standpoint, the doctor standpoint, all of this. I will tell you, what I don't want you to do is be discouraged if the physician or the IVF nurse contacts you, and it's usually the physician because we have a meeting afterwards with the patient, and says, everything actually looked pretty good. The thing we have to realize is, unfortunately, this is not 100%. And so that's sometimes the most difficult discussion we have, is the meeting after a failed transfer. And Kristin enlightened me. I did not honestly know this. It's called the WTF. Now, you know what WTF means, but there's another phrase for it. And Kristin's going to have to help me because I honestly can't remember it. That's the meeting after a failed transfer. What is it called?
When transfer fails.
Okay, that makes sense. When transfer fails. When transfers fail, those are very, very difficult conversations to have. But again, I will tell you, if we don't change the protocol, that doesn't mean it's the same thing over and it's not going to work again. However, I would also tell you, in those meetings that we have, again, on our IVF meetings, we very well may change the protocol and say, okay, her lining didn't meet the architectural kind of protocol or standpoint we want, or her estradiol level wasn't where it was, or can we do something different? Because like I said, there are a multitude of ways to do a protocol for a frozen embryo transfer as well. So just realize that if the transfer doesn't work and that WTF meeting is there are a couple routes we can go in terms of trying to have success in the future. And knock on wood, I think we've done a pretty good job of that, if we change things or not. So the biggest take-home point, again, for this is to say that there are a lot of kind of checks and balances and stops along the way for us, not necessarily for you, for us to know we are, one, all on the same page, two, trying to optimize as much we can, and then three, knowing what the patients obviously want in terms of moving forward with the transfer and afterwards, quite honestly. So just realize that this is still very individualized care, but from our standpoint, it's a group centered care to try to do the best we can for you. That's where I'm going to stop, Kristin, I think.
Thank you. Do you guys have questions? This is a time when you can unmute yourself or you can type in a question to him. Dr. Likes is volunteering his time to be available for you. Feel free to ask questions. Okay, and I see that I needed to hear all of that. She was disappointed when hers was canceled, but now she's hopeful. Yay. Hey, in the moment, hearing that it's not happening is awful, no matter who you are, what stage you are, whether you're new and the doctors don't like it either.
Yeah, so that's a great point. I appreciate that comment. If you're my patient, you probably heard me say ovaries don't always read the books. They don't always listen to what we want them to do. And there's only so much we can control. I'll be honest, there is. Excuse me. But that goes to the point of my saying, trying to optimize as much as we can too, because if we see something that just doesn't look like it should, what we're not going to do is just willy-nilly proceed and say, and I'm talking from a frozen transfer, so you already have the embryos. We're not just going to willy-nilly say, well, let's try this and just do the embryo transfer. And so you got to understand that it takes a lot for us to say, yeah, this isn't right. We need to hit the pause button and reset, because we also know that from a time standpoint, that is very difficult for y'all, because there's a lot of time invested in this. And we get to almost to the point where transfer, and then we say, oh, by the way, your uterine lining or your ovaries aren't doing what we need. We need to push the pause and reset. That we know is difficult, but you have to understand and hopefully trust that we're doing that for a very valid and good reason. So I appreciate that comment. So the question says, when you do the frozen transfer and restart all the medication, doesn't it re-stimulate follicle growth? And so, great question. So there are, like I said, there are different ways to do the frozen embryo transfer. I will tell you the kind of tried and true protocol is where, whether or not we do birth control pills, some clinics do, a lot of clinics do, some patients don't. Basically, birth control pills just kind of prep things and get the ovaries quiet. And same thing for if you're doing a stimulation or if you're doing a frozen. So they just keep your ovaries at bay so there's no endogenous fluctuation of the hormones. And then for a frozen transfer, what we do, like I said, the gold standard is we just give you estrogen. You actually take oral estrogen pills, and that's simply going to thicken the lining. But if we give you a high enough dose of estrogen, it will typically suppress the ovaries where you're not stimulating. I see some faces, but it doesn't. That's what I mean. It doesn't always. And so maybe we need to increase that estradiol. Having said that, there are stimulation protocols for the frozens that will actually use your ovaries and use your stimulation of your follicles and hormone production to do the transfer. So what I'm saying by that is we don't necessarily give you the oral estrogen. We give you medicines like you did in IVF to stimulate follicles, to stimulate the estrogen production of your own from your ovaries, to therefore thicken the lining on your own. That's kind of like a natural cycle, so to speak, but we're giving you enhanced medicines to hopefully induce the thickness of the lining and for preparation for this implantation. So that's what I mean by there's different ways. So to your question, it's hard to say this is the one way, but from the gold standard way, we will typically see that they will be suppressed enough where we can control the hormonal fluctuations. But again, I saw some faces, and I know that doesn't always work because the ovaries don't always play by the rules, so to speak. So Bronx, New York. Welcome, New York. Had a failed fresh transfer last month, currently preparing for a frozen embryo next month. Excellent. So you may be familiar with some of the things I'm saying, because again, a lot of the clinics, although there are different protocols, there seems to be a lot of pervasive themes amongst different clinics. I mean, I know I have friends in Texas, I have friends in Colorado, New York, actually, Virginia, and we talk. I mean, I'll text them and say, do y'all do this? Do you do this? And there is a big pervasive theme of how we do this. There's just, like I said, little tweaks every now and again that some clinics will put in to do that. So I'm hopeful for you, and I'm hopeful you're successful, obviously, next month. So good luck.
Okay, I got a question sent to me saying, if the IVF process isn't going well, will most doctors say, I think we need to stop this?
So great question too. It depends on what you mean by not going well. And so that goes back to the workup. And so the workup that we do, honestly, will say, one, do we think this is a good candidate for IVF? And so I tell patients all the time, and you can go back to my IVF talk. Actually, that was the very first conference we had, I think, back in April or May. But what I mean by that is IVF is a numbers game. And so we will do in the workup, we will check what's called ovarian reserve or egg number. And so we use that number to say, is IVF amenable, quite honestly, to this patient? Because if we tell them that we don't think we're going to get that many eggs and therefore IVF may not greatly increase your success, well, then do we even do IVF? But let's say, okay, well, we've done that. And yes, everything looks good and we're moving forward with IVF. As you go through, you're right, as you go through those monitoring stages, and typically we'll see you 4 to 5 times because it's about a 10 to 14 day stimulation window. If you're going through those stages and your ovaries aren't responding like we think they should after X amount of days, 5 days, 7 days, whatever the case is, yeah, we sometimes unfortunately cancel and say, okay, like I said, we're going to hit the pause or stop button and regroup. Sometimes if the patient's fallopian tubes are open, meaning they're not doing IVF because they've had a tubal ligation or they've had their tubes out, sometimes if they're open, we say, okay, we're just going to back down here and just let you try to conceive naturally. Even though you have 1 or 2 eggs coming about, that's not enough for IVF, but that doesn't mean you can't be pregnant if your tubes are open. So there's different ways to kind of, quote, downgrade the cycle if it's amenable to that as well. But yes, we will tell you that if we don't see the cycle going like we want it, and it's not, again, optimal for you, well, actually your primary physician usually has that conversation with you and saying, look, this is not going like we wanted. I'm willing to continue, but I think resetting would be better. So yes, we have those conversations. Another question, if the first cycle fails, do you ever consider trying for multiples for the second transfer? So I'm assuming you mean multiple embryo transfer, or excuse me, multiple embryos at the transfer and potentially having more than one baby? Is that kind of what you mean? So I get that question a lot as well, even from the get-go, because we're not immune to the fact that this is a costly, time invested experience. And so a lot of patients will say, well, if I have twins, that's great. I'm done, one and done. That's what they tell me. I hear that, but I'm very leery of that, because have I had patients with twins that of course go on and have completely normal pregnancies and wonderful deliveries? Absolutely, we have. But it's that small percentage that have the twins that are delivered at 28, 30 weeks, and they're in the NICU for X amount of time because you have multiples, and then so forth and so on. You can see the implications. And so I actually have a good friend of mine, some of the folks from New York may know him, Eric Foreman. He was at RMA with Richard Scott. He was a friend of mine at Duke, and he's now in Columbia. He did a paper that showed single embryo transfer. Now, granted, this was with genetic screening, so we know they're chromosomally normal, versus doing 2 untested embryos. The single embryo transfer by far was going to be the highest chance for a good outcome, so to speak. And so when you ask that question, I will tell you, I tend to shy away from saying, if you've done 1 transfer, we're going to do, and it failed, we're going to do 2 embryos this time to see if we can stack the deck in your favor. I don't typically do that. I really don't do that if there's a genetically tested chromosomally normal embryo each time. Because again, transferring 2, certainly in that situation, is not going to greatly increase your chance of success. It's just going to greatly increase your chance of multiples. The other thing you have to realize, and I'm sure you do, is that just like in nature, embryos can split. And so you can have identical twins. And so I have had, it wasn't me personally, but I know a patient who did a double embryo transfer, and she ended up with triplets because 1 split. So she had a set of identical twins and then a 3rd pregnancy inside as well. So that can happen. It's low percentage, but certainly you can do all the permutations in your head of what could potentially happen. And just like in nature, I mean, triplets in nature happen. It's rare, but it happens. So we really are trying to again, because the technology and success is to where it is, we're trying to use that to lessen the risk of multiples. That's the bottom line.
It's like a day in the life, right?
That's right.
I'm glad to have the opportunity to go through in a little bit more detail than what I could probably do on like an Instagram story on the benefit of coaching and what coaching is. And so I'm glad you're here to listen to find out more. So the biggest question I get is the difference between coaching and therapy. And the way I was trained about it is that therapy is something you actually get a degree in from school, and you have to be certified on a state-by-state basis. The other thing that's very different between coaching and therapy is that therapy looks at the past and things that have happened in your past that are impacting your quality of life now, and is more about fixing or healing wounds from the past. Coaching, on the other hand, there's actually no certification or degree required to be a life coach. Actually, nothing. That being said, there are ways to get certified. I think some people believe more in it, and there's accreditations and certifications that you can get. So the life coaching certification that you can get would be meaning that you can work with anybody, anywhere. There's no limitations on where you're located. Also, coaching is more about taking something that's good or okay and making it better or best or awesome. It's also about looking forward. It's about setting a goal and working towards moving forward to reach that goal. So the biggest difference is either looking back and fixing and healing, or moving forward and reaching a goal. So those are the biggest differences that are between coaching and therapy. I believe that having a life coach will actually change your life. And it impacted my life so much that I wanted to get involved myself to do it. Coaching can be offered in a lot of different ways. Most people will do one-on-one coaching. So that's one-on-one in person, one-on-one over the phone or over Zoom or other video conferencing. The other option is group coaching. That usually means that there's more people, and it's kind of like this, where you're doing the Zoom call with multiple people. And that means you have to be more open about sharing what you're going through with the group, because it's not one-on-one necessarily. There's benefits, there's pros and cons to both of it. It's really about what makes you feel the most comfortable and fits for your life and schedule. Coaching can be 1 time a week, 2 times a month, 1 time a month. And so whether that's one-on-one or group coaching, it's the same thing. And then there's some life coaches that are just general life coaches. They will work with anyone about anything. And there are other people who specify a niche or a specialty. So that could be like a weight loss coach or a relationships coach. There's coaches who help people try and get married who are single. There are coaches who help people lose weight, business coaches, even entrepreneurial coaches and sales coaches. In my experience, I've chosen to focus on infertility and women, working with women going through IVF. So that is my niche. There are other infertility coaches as well, but you can certainly work with a life coach and talk about infertility or not. But also, as somebody who specializes in infertility, I still am able to work on lots of other things, like every aspect of your life, because that's what I was trained in by getting my certification. To tell you a little bit about the value of coaching and what it can really do, and maybe you guys should start drinking every time I say coaching, because I've already said it 40 times. All right, I like it. We'll have to have a nature break maybe. Yeah, that's a little awkward, but we're gonna go with it. This is what I do, coaching. Okay, just imagine you going through all of the IVF process, all the monitoring appointments, and realizing that your life was not put on hold in the meantime. Like, imagine going through and realizing that your relationship got better with your spouse, with your parents, with your coworkers, with your fertile friends who always say the wrong thing, who seem to make it really awkward every time they ask about what's going on or don't ask. Imagine not feeling triggered every time you hear about a pregnancy announcement. Imagine loving your body and knowing that it is doing everything it can do, and that you are doing everything you can do, that you've got a team, like Dr. Likes just shared, you've got a team of people behind you working on you on the medical side, and you're doing what you can on your side. You can sleep better at night. You have more energy. All of these things are benefits and side effects of working together with a coach, because life coaching really does impact everything in your life. So when I think of the value of coaching, there's value in the perspective of working with somebody else, somebody who's been through it. That mattered a lot to me. I specifically wanted to work with somebody who'd gone through IVF because of all the language, because of the alphabet soup, because of the things to say and not to say. That might not be what everybody wants or needs. That was a special thing for me. So that's what I can offer. I can work with women who are going through IVF because I've gone through IVF and I know what that's all like. But also, I bring the perspective of being at the top of the mountain that you are climbing. I have a different viewpoint. I can see the whole forest, the whole mountain, and I can tell you how you can take the next step to move forward. I always work with people who are working with doctors and are going through IVF. I am not trying to that's not my lane at all. I am just there to give perspective on other practices or other ideas, to also help you advocate for yourself if you need to, if you're not getting the bedside manner you want, letting you know. So, I can't tell you, every client of mine, I have had to reassure that she's not the needy client by asking the nurse for more specific information. And Dr. Likes is smiling because he knows. I'm sure every woman thinks they're the worst case patient asking for one. He knows, because we're all hormonal. Like, there's an expectation. And so you are worth asking and getting the information you want. And so many of my clients just need to hear that to then make that phone call. I also can provide sound judgment because I'm not in the weeds and I'm not hormonal and I'm not pregnant and I'm not trying anymore. And so there is real value in that perspective. There's also so much value in firsthand experience. And one of the most expensive ways to learn something is to do it yourself. And so I am a big sister. I have always been giving advice about the things that I've learned. And that's one of the things that I do alongside with my coaching is share some of that value. Another piece of value of working with the coach is it's like a team effort. Infertility makes you feel so alone and isolated, and having a teammate who is coming to you from a place of love, who's coming for you, cheering for you, rooting for you. They believe in you and they believe for you when you don't. I know that there are days and moments where you don't believe anymore, even if you're doing all the right things. But that's what I can hold the space for that for you. So until you believe again. One person told me that a coach is your very own personal champion. They have your best interest at heart. And they give you the space to believe it can happen. So often there's steps and moments every month when you're going through infertility that are kind of showing you like this might not work or it hasn't happened yet. And so when you're going through something really hard, it's really nice to talk to somebody who believes in you and believes it is possible. So there's also the value is having dedicated time week after week to spend time believing, having like vision moments and thinking about the future and what it's going to be like when you're pregnant and when it works and when things are easier and when you know that what you're doing, you're not second guessing every choice of yours. A coach is somebody who sees you like in the future version, like the future self of you. And it's really cool to be around that. That's magnetic and that's going to motivate and inspire you. It's also dedicated time to work on you. And so many of us are just going through the hustle and bustle of the day-to-day life, and we don't put ourselves at the top of our to-do list. So sometimes just even having an hour of time dedicated to you each week it's life-changing, just that. It also is space to talk it out. You get to talk out whatever you are feeling, whatever you're going through. Coaching is, it's about you and what you need. There's also commitment. When you sign up with a coach, you have accountability. You can't make excuses anymore. They're going to tell you the truth. Sometimes it might not be what you want to hear, but it's also helping you get the results you want and no longer quitting on yourself. It's safe. It's a place to vent. It's 100% confidential. There are guidelines and expectations about that. It's time all about you. It's like talking to a best friend or a big sister where they actually know the answer or know about the information, but also they don't start talking about themselves. It's all about you in that moment. But you can vent. You can vent, and sorry, Nathan, but you can vent about your partner, maybe when they're not doing the right thing at the moment. You can vent about your awkward coworker who keeps asking you when you're going to have a baby and plan your maternity leave, and you're like, please go away. We don't want to talk about this. You can vent about your friends who keep popping out babies and COVID babies and holiday babies and all the things. It's a safe space to really show up as you. I know a lot of times you also have to be strong for your partner or for your family members and say, I've got this, I can do this. But I also know it's really hard. And so working with the coach gives you the space to show up and say, it was really hard today, and I don't know if I can do it anymore. And sometimes you need that space for you. Okay, and the last thing I'll say about it is that it's fun. It is like talking with a best friend or a big sister. It is somebody holding your hand every step of the way, here for the hard days and also the good days, but mostly for the hard days so that you don't have to do it alone. So that is why I love talking about coaching. Drink. It can literally change your life. You get new perspective. You're not going through it alone. You get the value of somebody who's done it and understands and says the right thing. And somebody's walking alongside with you who believes in you and knows that you can do anything and that you will be okay no matter what happens. When I work with clients, I work one-on-one. That's what I offer, working with clients. And we work on 4 things mainly. Growing your belief that it can happen, that you can do hard things and that it will work. We work on knowing what to expect every step of the way. Like, what are the possible outcomes? What should you expect related on where you are? You learn tips and tactics and strategies to reduce the stress, fear, and anxieties, because the longer you're in it, the harder it seems to be. It doesn't seem to get easier. And then we also work on getting you back in the driver's seat and getting back in control so that you can make time for yourself, for your partner, for fun. You can keep working and rocking at your job and not be falling behind your friends and having the life you really want. So that is my coaching. And if you are listening and you're like, I need that, I want that, I'm ready, the next thing to do is to set up a call by filling out an application and setting up a free call with me. And we will talk all about it to see if I think I can work with you and help you based on your specific thing. Just like Dr. Like said, it's really one-on-one. Coaching is one-on-one. It's about what you need. And if I can't help you, I can refer you to other people too, because there are a lot of coaches. I really believe that everybody in life can benefit from a life coach. I would love to work with you if you are ready for that. All that said, Dr. Likes, thank you for coming again.
Yeah,
the 8th month, we've done it. This is awesome. We're gonna have a
Well,
whole library.
Good.
Yeah, a whole library worth. Yes, thank you. I'm so glad that we've been doing this and that you're able to join again. And thank you for your time.
Absolutely.
Donating your time.
All right. Thanks, y'all. Take care.
Bye.
Bye-bye.